Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I am joined by another nurse and a pharmacist. Welcome, Lyle and Jena.
Hi, Rosa.
Hello. Thank you for
Now,
having us.
I am going to let each of you introduce yourselves to our audience. We've got viewers on YouTube, but we also have people listening. So I'll let you explain who is who and how you work together.
Jenna, you go first.
Okay. Hi, guys. Thank you for your time today, Rosa. My name's Jena Quinn. I'm the CEO and co-founder of Perfecting Peds, which I'm sure we'll get into. I am by training and still practice and see patients, although they try to take them from my fingertips more and more every day. But 14 years I've been a pediatric pharmacist. So we're specially trained. We get our PharmD like all pharmacists, but then we do residency training and board certification. I practiced 10 years in the hospital at Children's Hospital of Philadelphia, which you'll hear in my terrible Philly accent, and Cooper University in Camden, New Jersey before founding this company. And most importantly, my best job is I'm a mom of 3 little girls.
Oh, that's awesome.
Thanks, Jenna. I'm Lyle Mioduszewski. I'm president and one of the founders here at Perfecting Peds. My background has been in healthcare exclusively for the last 22 years. It's all I know. I'm obsessed with it. Ask Jenna. I probably drive her nuts.
Hey, she's in healthcare too. She's numb to it.
She is equally obsessed.
Yes.
I live in Southwest Florida. I also have 3 kids, 10, 8, and 6, and I'm married to my wife, Sam. Started my career out as a nurse, been in solutions and strategies all across the board, startups and big companies for the last 10 years, and been here at Perfecting Peds for about 2.5.
Fantastic. I'm so excited to have both of you here. And before we get further back into your stories, tell us a little bit about Perfecting Peds that you are working on together and how you came to be working together on it, because you founded this company together, right?
We did. I started it a little bit, probably a year before.
Okay.
Just kind of feeling my way in the dark. I had no strategy. I just saw a problem and I was like, I have to figure out a way to fix this. So working at the hospital's CHOP in Cooper, I was the pediatric ICU pharmacist, the neonatal ICU pharmacist, and the Peds ED. So they would float me all around. But what I would notice is that a lot of our kiddos that were medically complex, so if they had more medications, more disease states, they would come in, they'd be a polypharmacy nightmare, meaning that, no one was looking across the entire regimen or constantly asking is this medication needed? We have become really good in kids to add another medication upon another medication. And so when they would be admitted, a lot of times it was a preventable medication error. And I didn't know who, or really couldn't figure out why this was such an issue, but at least locally in New Jersey, I was able to identify that the most medically complex kids were in some sort of skilled nursing in the area. So we had a long-term rehab, a couple medical daycares, and a subacute rehab that housed our medically complex kids in New Jersey. So long story short, I have a fun background. I'm also selling skincare. So I put my my sales girl hat on. Fun fact. It was like how I became part-time in the hospital before I founded this company.
Okay.
Put my sales girl hat on and went to the CEO there and said, I think that you may have a problem that you're not aware of. These kids are coming into the hospital with completely preventable medication errors. Would you do a value-based care contract with me? So I said, there's 400 patients. Me and a group of pharmacists will work on these kiddos month after month after month. At the end of that 1 year, we'll study it, see what happens. And I was very, very confident that if we became a member of the healthcare team, just like a nurse, just like a doctor, any of the specialists, and really embedded ourselves in with the families and the patients, that I was projecting and hypothesizing that we'd be able to keep them out of the hospital. Our first study was published in the Journal of Pediatric Pharmacy and Therapeutics, which summarized this first year of the of Perfecting Peds, but it showed a average of 13 interventions per child, which equated to objectively a 44% reduction in hospitalization. So
Wow.
showing year 0 before Perfecting Peds, in year 1, we were able to decrease hospitalizations by 44%. And then it showed back in 2021 an 11K decrease total cost of care per each kiddo.
Wow. And this is comparing that child's own hospitalizations the previous year, not just overall kind of readmissions of similar cases.
Yes, correct. And so I did, like, again, I don't have a business background, but I knew, like, clinically, I'm like, this works. Like, if we put the pediatric pharmacists who, as I explained to parents, were like the most highly trained dorks in medication and kids. If we put us in these kiddos' care longitudinally, that we would be able to partner with the providers and the parents and the patient to keep them out of the hospital. And so once I had those study outcomes, I was like, all right, I need somebody that's good at sales, at growth and strategy. Even 5 years in almost, I'm truly a clinician at heart. And I met Lyle on Y Combinator Founders Match.
Oh,
So you could go on, put like your idea, what you were looking for in a co-founder. And after dating many frogs, I, I was about to throw in the towel. My husband's like, you're talking to a lot of men and I don't know what's going on. It kept partnering me only with males. And then finally, Lyle, seriously, like 60th person I talked to, I'm like, just don't think I'm going to find it. And then Lyle came into my life and really put the business spin and our long-term growth and strategy plan to market. So very lucky to have him in my life.
aw, that is so amazing. I wondered why our mutual friend Brian was calling Lyle the prince.
He
Yeah.
does, doesn't he? He really does.
Yeah.
Well,
I call-
it's like it has a word in front. He calls me the Polish prince because he's
He
also
does. I was
Polish.
leaving that out because I didn't know how you felt about that.
Oh no, I love it. I love
You
it.
love it?
Well, his last name is Urban, and I call him Urbanski. So
That's
it goes
fair.
both ways.
That's fair. As long you could just call each other cousin, whatever. So, Lyle, you said you were working in like the business side of healthcare and startups for like a decade before this. Is that right?
Yeah, the end of my bedside journey, I was in the cath lab, and was around sales reps all the time, and I kind of took interest to it. I thought it would be kind of the next challenge. I had started in ER. I did neurocare like you do, Rosa, immediately out of school. And then I got into procedural nursing, really liked it. And then thought, geez, the sales reps in the cath lab are doing a job that I think I can do. I like talking to people. I could vary things up a little bit. Stuck my neck out and worked for a defibrillator company at first, and then have done several things. Most recently, before I met Jena, was working in risk adjustment in Medicare Advantage, and a little bit of social determinants of health data, when there was a consideration that might be a component of risk adjustment. And so that social part of it didn't happen. I think that was the thing that I related to as a bedside nurse. Not like the actuarial considerations around capitation and the things that determine rates that the government pays for lives, but really like how we could give more to the right groups of people, not just based on their diagnoses. So that was something I was interested in. It didn't go well for the entire industry. It never became a coefficient of risk adjustment, and I got to a point where I just needed to get back closer to the patient in any way that I could. And what Jena had proved with the initial outcomes of that implementation she just went through was seriously meaningful. And I don't see a lot of innovation and a lot of companies out there that are rearranged. Like, there's a lot of inventative stuff. Like, people create solutions and drugs and transplanting different organs and all these different interventions, but there's not a lot of rearranging of the things that already exist to make it better. And I think that that's what Jena did, right? Like there's nothing brand new here. It's moving some level of focus and expertise from one setting to another, making it accessible to lots of people, and really
Yes.
understanding that the majority of kids that are on lots of therapies in this country are living at home. They're hard to get a hold of if it's not for their insurance company, and we could get to them through that way. And so
Mm,
we've been doing that for the last couple of years, and it's been going overwhelmingly well.
that's fantastic. What is your favorite thing that you have accomplished since you've been working together?
I'm gonna go from the business angle, and Jena, I'm gonna guess you're gonna go from a patient care angle, but I think they both feed into each other. I can go first. So, not having having domain expertise in nursing and sales.
Mhm.
I didn't have any idea of what it meant to create a business, and that has been the most unpredictable journey outside of being a father and a husband that I've ever experienced, and completely unpredictable. Um, the the main part of that is people,
Mhm.
and learning trust in people, and when to give that trust and when not to.
That's
And
hard.
so I think the greatest thing that's come out of this is like that Perfecting Peds is still a business. We're
Mhm.
continuing to take patients in, expand our reach into them, and hopefully like proliferate and be ubiquitous in medication management for kids in the United States here at some point in the future. So for me, the best thing that's come out of it is we figured out at least so far, and we're still small
Yeah,
and relatively new in the grand scheme of things, but how to keep this thing going.
it's very exciting. And what about you, Jenna?
I will echo that there is always turmoil in a startup. So the fact that we've been able to continuously come out the other side on the same page over and over and over again, considering that we just randomly met 2.5 years ago, is pretty phenomenal. And we always say that all the time, like, wow, this is could have gone so many different ways. So that's really cool. We're usually, and if not, and we have a disagreement, it's a very respectful disagreement. It's not, it's so again, the relationship through the turmoil has been really, really tried and true. I think I'm going to give you two answers. The one cool thing that I didn't anticipate is we've been able to elevate the pharmacist as a provider, right? So we've always been, I think of my grandfather. So my grandfather was a pharmacist. He was a compound pharmacist. It wasn't like you use your cognitive ability. Yes, you do as a pharmacist, but he was so focused on how do I compound this med correctly? Like that was his focus. And now, like especially right before he passed, I told him, he's like, I'm so confused by this. He's like, you're going to use like your cognitive ability and you're going to work from home and you're not going to like dispense any meds. And so it's really putting a pharmacist where I'm going to age myself, but 14, 15 years ago, there was some training on how to be a provider, but not as extensive as like a PA or an MP. And so it's been cool to through laws that like we're slowly passing through like Pennsylvania, Minnesota, et cetera, that we're becoming a provider and we're figuring it out as a business. So elevating the pharmacist as a profession has been really cool. And then we take students from 7 different universities and we constantly have tons of students. And so without Perfecting Peds, a lot of them wouldn't have the ability to have any contact in the specialty of pediatrics. And so in pharmacy school in the US, some schools have a pediatric elective, most do not. And so a lot of almost, I would say 99% of pharmacists graduate from pharmacy school with no pediatric expertise at all. So
Well, what?
there's 1,700 of us in the US. Fun fact. Yeah.
So, can you explain to me why that is? Do they just not have the relationships with pediatric centers to arrange those electives to be available?
Yeah, so, like, I went to Rutgers, which is, like, one of the schools that actually is heavy peds, so we had, like, 3 pediatric faculty. It was an elective. We could do rotations with the pediatric pharmacy faculty, but that is not the norm because there's not enough of us. And in general, as a society in healthcare, we're really focused on the adult. So all the pharmacists come out really equipped to take care of a geriatric and adult patient, not equipped at all to take care of a pediatric patient. I had no exposure until my 5th year of pharmacy school when I had elective in peds.
Wow.
And my sister, growing up with a sister with epilepsy, I knew, like, however I was going to figure it out, I was going to niche into peds. But because of all that, like, now we've opened the door for so many students, and a lot of our students that spend time with us in electives and on rotations then go on to do residencies and become a pediatric pharmacist. So would have never imagined that in my wildest dreams. And then, as Lyle already said, starting this off from 100, 100 patients, now getting to almost 10,000 patients eligible. It's so cool because I could have never imagined in our wildest dream that we get there. We would gotten here, and we're figuring it out. So it's really cool to help that many families and that many patients.
That's amazing. And I love that you're duplicating yourself as a provider, as a pharmacist, by opening up this door of opportunity for more pharmacists to niche down into peds, as you were talking about. And that specialization is so important. I know several of my favorite pharmacists are the critical care pharmacists that I worked with. I'm going to give a shout out to Patrick at the hospital that I worked at last. And he was our critical care pharmacist. And like our physicians really respected his knowledge and deferred to a lot of his advice. And I mean, it's so important because there's so much complexity, and you guys are so good at being detail oriented. And
No fault.
um, I really, really value how you'd need to know the population that you're working with because there are so many differences. But I mean, when it comes to polypharmacy, I think in geriatrics, they say, if you have more than 8 meds, you need to start cutting them down and try to get to 8 or less. So I would hope there is at least some kind of similar principle for kids. Obviously, 8 sounds like way too much to me. But what would you say is something you would wish every pharmacist knew about polypharmacy that they could take away from this episode for kids?
Yeah, I think a couple things. So I'll start with the easiest because you got me on a subject that I'm really passionate about. Lyle's like, oh God, here she goes.
No, this is great.
You open the floodgates. Um, so the first thing is like the 101 of peds, which is it's weight based, right? So like, and their disease states are constantly changing. So one of the like simple things for polypharmacy is you have a kid and they're on a PPI, which I feel like we put every kid on long-term PPIs and they're terrible. They cause pneumonia, they cause C. diff, they cause osteopenia, they cause B12 deficiencies, which then cause psych issues. They decrease your, all the things that like, and I'm embarrassed to say back in the day, we like thought they were safe, right? One example and the simplest way to cut back on polypharmacy is to constantly assess where the kids' meds are in a weight-based fashion. So, you know, a lot of kids are started on these meds and nobody ever pauses to ask the questions, and some during infancy. So you think of our NICU grads, they are started on a PPI when they leave the NICU at 2 months and nobody's asking, do they still need the PPI? And the dork in me, will rattle off all the side effects: pneumonia, C. diff, osteopenia, vitamin deficiencies, and they're not benign drugs. And so one of the easiest things to say is, hey, this kiddo's doubled in weight. Their medication is at half the efficacious dose. Is it possible that they don't need it anymore? That is not a question that's asked by a lot of providers. It's kind of just continued. And one of my biggest bugaboos is when you can't even find the original prescriber, and then they're like, well, I just continued it because the kiddo was on. And so that is like the easiest, simplest piece of advice that I wish everyone knew is like check the weight base. If it's half as efficacious, do they need it anymore? Just pausing and asking, hey, a lot of things have changed. Like using GERD as an example, around 1 to 2, a lot of kiddos grow out of it. And so, and not committing these kids for life to these medications, which I'm all about meds, but only when they're needed.
Exactly. And like you said, I mean, we're trying to solve a problem, not add new problems by causing new drug complications.
Yes.
Definitely. Well, I think that brings us to the $1 billion question, which I'll pose to each of you. And Lyle, if you were given a grant for $1 billion to meet a need that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
I'm going to allow Jena to use our collective $1 billion solution, which I think she's
Sure.
going to say is weights on scripts.
Since
Um,
we know she really cares about that.
we do. I'm
I
not stealing it
do.
from
I have
her.
another one now.
Oh,
Oh,
she
well,
has more.
you can have 2 billion.
Let's do
I'll
it.
take one. We'll get three together. My $1 billion is not like anything that hasn't been discussed before, but I'm really passionate about it. It's removing the patient as the medical historian from
Ooh,
their own care and having a unified patient record to achieve that. I think we keep taking incremental steps toward it.
yeah.
And then there's like all of these parameters that have to be put in place to protect us, right? Like we have HIPAA to worry about. We don't want certain components of the healthcare system, whether that's a risk bearer or a provider getting certain portions of that record based on their permission type. And I think that's detrimental to all of us. And if we're able to consent and give our medical information to those who can make the decisions about it, whether that's a practitioner sitting in front of us, it's an algorithm that can decide what's going on in the best course of action or whatever it is. If we can get that stuff into one single place, that's my non-unique $1 billion. What I would do with $1 billion, I would want to put it into that. I know there's a
Well,
lot of companies solving for that today already.
right. It's a very big problem that I think that would be a great solution for someone who's listening to this who doesn't understand why that matters. Could you describe that?
Yeah, your data's all over the place. So like the electronic medical record is privatized. The data that comes out of that is uh, it's held by usually a private company, and to get it out, it has to be permissible, right? And so if my doctor is on one electronic medical records system owned by a company, and then I go to another doctor who's on a different system, they might not be able to see, and they're typically relying on you to fill out that form in the lobby to say, "Here's my conditions. Here's my family history." What it doesn't ask you are some of the things that are really important. What have my hospitalizations look like? How have my labs trended? What's been going on with my disease states over time? And that's something that is very easy if we normalize that information and make it accessible to all of those treating providers. There
Well,
are means to do that today, especially
right.
for treatment, but it costs money. So like my doctor, who has a very fixed income, if you want to call it that, because of reimbursement being schedule based and determined by the health plans or the government, they don't have the means to go out and buy those solutions that aggregate that clinical data and get a better clinical picture of you. If that was made available or it was more affordable, maybe they could.
So let me clarify what all we're talking about here because, for example, if you go between health systems, we can use Care Everywhere to see the medical record from like previous hospital stays at other locations.
Mhm.
And the different electronic health records can speak to one another. So there is that way for that electronic transmission. But are you talking about the barriers in more like smaller private practices where they don't have access to that larger electronic health record because of the cost barrier?
Absolutely. And don't get me wrong, like again, we have been incrementally taking steps toward that since meaningful use in the early 2010s, right? Like we mandated through the Affordable Care Act that providers would adopt medical records. We subsidized their adoption of those medical records. We forced them into it. but not one single company. So when you say Care Everywhere, that is one company's proprietary health information exchange per se.
But they all
Now,
have to be translatable across FHIR, right?
correct.
Between systems.
So now we're at this point of like QHINs and those systems, the Epics and the Cerners, and then so on and so forth are participating in that. So as somebody who's delivering care in a clinic or ambulatory care, and my doctor, I don't usually go to the hospital when I need my blood pressure monitored, right? Or treated. I go to my doctor. If their practice is owned by that health system and they've given them instance access to their EMR, then maybe they do have some of that information available. But if they want to see what I had done at my dermatologist who has some EMR that I just logged in their patient portal and I've never even heard of the EMR
Yeah,
before, I
right.
don't know where that is. It's not readily
Mhm.
accessible. We
Exactly.
have the capability and the wherewithal to do this and put it in front of the provider proactively,
Right.
summarized and actionable. We've had that capability for a very, 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 very long time. There's many reasons why it's not where I think it should be. And does $1 billion solve it? Probably not, but I would love to see that as a consumer of healthcare and as
Mhm.
somebody who watches patients inaccurately report their own history and then get
They
inappropriate treatment from it.
they don't know what meds they're on, they don't know what their conditions are. They might tell you they have 10 things that they don't, or they might be in denial about the 10 things they do have.
So much there.
Yeah, there's so much room for error there, so I'm with you on the transparency of information, but
My mom, just like one example too here, Rosa, is I know my mom's healthcare pretty well.
yeah.
I definitely don't know all of it. There are things of it that she probably doesn't share with me. She has hypertrophic cardiomyopathy and she goes into AFib. And her AFib is not like your standard patient who comes in the hospital, AFib, RVR, their heart rate's going really high. We give them some cardizem, it usually comes down. Like she goes into hemodynamically unstable mode, blood pressure in the tank. And if you give her cardizem and you give her the standard treatment, it does very bad things to her. This is something that should follow her digitally. Instead,
Mhm.
I have a laminated piece of paper that I wrote out her treatment cascade and what's appropriate and not for AFib in with RVR in a
Oh,
HOCM patient, and she
you
has
are
that
such a
laminated.
good nurse, look at you, you're
She
sending
shouldn't
my
have to
whole
do that
care
though.
plan with her.
Thank you, but she shouldn't have to do that is my point.
Yeah.
She shouldn't have to do that. Not
She's
in
lucky
today's
and happy,
age.
though. Yeah,
Cheers.
wow. Alright, well, we're gonna give Jenna a turn. Jenna, if I
Okay.
give you $1 billion, what need would you meet?
I know, exactly. It's hard when you have so many great ADHD ideas. So my brain's a mile a minute right now. But probably one of the things, and hopefully one of our many iterations of our care company. I think Lyle's always overwhelmed by the amount of continuous ideas. But one of my biggest pet peeves is really the lack of guidance that we provide to patients, specifically caregivers, on over the counter medications, right? So we say they're safe. We leave them in the aisle. They're not mandated to talk to a pharmacist if they want to. Yes, they can. Whether or not they're peach trained, I don't know. But with that, like, you tell a parent, okay, they buy ibuprofen. There's two formulations of ibuprofen. Most doctors will just give you an ml dose. But the first thing we should be asking is, which of the two did you pick up at the store? Did you pick up the 100 per 20, but the 100 per 5 mLs, 100 milligrams per 5 mLs, or did you pick up the 50 per 1.25 ml? Because that's double. So most providers are very quick to just say, okay, it must be the 100 milligrams per 5 ml and rattle off an ml dose, but there's that infant ibuprofen that is still readily available. So if I just gave it to them in the one that's more commercially available, I could potentially 2 times overdose them on ibuprofen. The parents have no guidance on the back of the bottle on any of these bottles. For anyone less than 2, it says consult your provider. And so I've become like the neighborhood pharmacist. Anyone, mom or dad, knows they can text me at any time. I'll do a quick calculation and I'll text them right back. But what I will do is say, send me a picture of the bottle. Because if you ask them what's the concentration, they look at you like you're crazy.
Right.
And so you think about all these parents that in the middle of the night, they have this bottle and they're like, I don't know what the heck to do with it. And sometimes there's not a readily available provider. And so, I mean, the examples are endless, especially in kids. Like the doctor will say, this happened to me the other, with my oldest, excuse me, she has constipation. One day she's going to kill me because all I talk about is her functional constipation. When she's grown and dating, she's going to hate me. But right now I can get away with it. But she sometimes needs enemas. And so, during a period of her life now, they would say give a pediatric fleet enema. Well, all the enemas look the same, and a lot of places don't have pediatric fleet. So, how would a parent know to take the regular fleets, that's the sodium bisphosphonate, dump half of it out, and that would be a peds fleet? Or that if you give it under someone the age of 2, that you can actually cause hyperphosphatemic death. So the examples are really morbid, and my clinical excitingness could go on and on and on. But I think just providing a safety net for them, whether it's an app, whether it's an app attached to a service, there has to be a better way
Yeah.
to keep these kiddos safe with over-the-counter medications.
Yeah. I mean, pretty soon you would think everybody's going to be asking their chat GPT or their Gemini or whatever their AI of choice is. So,
Mhm.
but there's no guarantee what that thing's going to tell them. So,
Yeah, or
Yes.
where it's pulling from. I think the thing on like no don't if you don't if I like even as a nurse, if I see a medication bottle and there's no dosage for my kid's age or weight, I'm like, oh, then they can't take it. But that's not actually the case. And I think that's one of the things you're getting at, Jenna.
Yeah.
mhm.
Yeah. There's
Yeah.
just not a lot of safety provided for the caregivers.
I've
Uh,
definitely asked pharmacists to help me, like, do that calculation for the weight-based drug, though. Like, I will probably say I'm a nurse, and I don't trust myself to do this math on children. I learned on grown-ups. I'm not used to this size. You know what I mean? It's just, ooh, I got
I think
spoiled.
like that was one of the things when we were talking at the beginning of the podcast is um Jenna's grandfather, who was a pharmacist himself, like couldn't pull his head around clinical pharmacy. And most people in healthcare, unless they've worked in acute care, like you don't really know what that even means or what's going on, or that's a profession that's happening. Like we know if we've worked in acute care, like
Mhm.
they're right here with us, but nobody knows. And nobody knows that they're making therapeutic clinical decisions and they're saving our asses all the time.
All the time. Yes,
I love my
definitely. Or
nurses.
and creating processes and protocols to set set protective,
The fun, the
in
fun
place.
fact, Rosa,
What'd you
Perfecting Peds is named Perfecting Peds after a pharmacist, especially if you're a pediatric pharmacist, you're a breed of a breed. Like we have baseline OCD, then you add pediatrics and you're just freaking crazy. And so it is after perfectionism that comes in line with if you're a peds pharmacist, you are a perfectionist by need. So yes, we have lots of protocols, lots of policies. We color inside the lines at all times. So that is how I came up with the name.
will not be showing you my coloring book.
So funny.
Oh, but that's great. Well, you two are an inspiration and you are giving me hope for humanity that, the future can be better for our kids and you're doing it now. The future is now. So, I'm so thankful that you took the time to be with us today. And I know you're going to keep up the good work. If anybody wants to reach out to you to learn how they can partner with you, what's the best way to reach you?
You- Info at perfectingpeds.com is our inbox, perfectingpeds.com and Perfecting Peds on any social.
That's right. That's right. And you're both on LinkedIn, right?
Yes.
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 I'm an avid LinkedIner. I love LinkedIn. You make
I
the
love
best relationships there.
It's so true. I love LinkedIn. You can definitely find me on LinkedIn as well, and all the socials at Nurse Rosa Speaks. And then if you're listening to this podcast and you enjoyed it, please press like and subscribe wherever you're listening, or if you're watching on YouTube. And feel free to send me a message and let me know if you have an idea or know someone who has a $1 billion idea that can make healthcare better, because I would love to spotlight it. So maybe somebody will actually throw money at it and run with it. And I will see you all in the next episode.
Thank you.